To the next session now. I know our last topic generated a lot of conversation, a lot of energy, and a lot of ideas, and I think we need to definitely continue this. But I'm June Hanke. I work with at Harris Health System in Houston, Texas, and I'm the co-chair of the community committee for the collaborative. And next, we are going to have Dr. Giwa presenting, and she's going to be talking to us about prenatal care and hypertension detection and treatment. Dr. Erica Giwa is an assistant professor of obstetrics and gynecology at College of Medicine. She currently serves the medical director of obstetrics and gynecology at the Center for Children and Women's. She is a Houston native and decided early in her life to pursue a career in medicine. After she attended Michael E. DeBakey High School for Healthcare Professionals, she graduated from the University of Houston with a Bachelor of Science in Biology. Her training then led her to Dallas, where she received her medical degree from UT Southwestern Medical Center. Subsequently, she returned to her hometown to complete an internship in residency in obstetrics and gynecology at UT Houston Lyndon B. Johnson Hospital. For the past 2 years, Dr. Giwa has had the awesome privilege of working with several partners in Harris County to tackle the issue of maternal mortality. She currently serves on the Houston Endowment Improving Maternal Health Steering Committee, as well as the March of Dimes Health Equity Steering Committee. And I'd just like to say Dr. Giwa is an awesome woman. She's done a lot in her practice, and she does a lot for women in our community. And I really enjoy working with her, and I look forward to hearing her presentation. I'll see if I followed all of what John told me to do. Voila. There you go.
So do I just click on here?
Yeah, he said
Okay.
you use these or that.
Thank you so much for that introduction, June. I like to be introduced by June. She makes me sound great. So this is actually my first time at this conference, and I've learned so much so far. So I'm going to go ahead and jump into the slides because I actually think I have too many. So we're going to get started. These are the objectives for today. I'm going to overview the pregnancy medical home model. I know the intent is to talk about kind of coordinating care in the community, so we'll talk about that. We'll also review the diagnostic criteria for the hypertensive spectrum, discuss collaborative management of patients, and review the 4th trimester. So if this is not where you thought you were going to be, you can leave now. Okay, so what is a medical home? I am a safety net provider. I work in a medical home model. I'm the medical director for obstetrics and gynecology. Before that, I was in private practice. So I remember when I was making the transition, I talked to my now boss, and she told me, we're going to do something innovative. We're going to care for women with a focus on quality, collaborative care. It's a medical home. And I was like, okay, I'm on board. But I had no idea what a medical home was. I thought people were living there. It was really weird. But, I was on board. So people do not live at our practice. It is a primary care model designed to center around the patient. It's team-based, collaborative, with a focus on quality and safety. So some of the hallmarks are increased access to care. The way that we do that is have many medical homes will have multiple locations and have extended business hours beyond that typical 40-hour work week. We also have a team-based approach with multiple service lines under one roof. So in my practice, we actually have 13 service lines under one roof. The major service lines are obstetrics and gynecology, but we have so many other support services to help us provide the best care. And so I don't know how many of you were in the previous session on postpartum depression, but those are things that this collaborative care model helps us address. So when I give a patient a postpartum depression screen and she screens positive, I can just pick up my phone and call behavioral health and they come over and see her. When I have a patient who needs a prescription, I can just send it right over to the pharmacy that's under my same roof. So this makes a world of difference in the care for patients, particularly in the high-risk patients that we'll discuss today. So as I said, the medical home model puts the patient at the center. All these services collaborated around them to provide the best care for the patient and the family. So some of you have probably seen this little man, woman. before, but I like to point this out because when we are talking about the care of the patient, there are so many things that go into providing the best care. So when I trained, I feel like I trained to do the bottom 50%. So we do a really good job with one-on-one, face-to-face interaction, do a really good job about asking your social history, do you smoke, do you do drugs, and all of that. So, but we don't do the top very well. I won't speak for anyone else. I don't feel like I did the top very well as a private practitioner. So if we're not focusing on the physical environment, not focusing on the other social determinants of health, a lot of times we cannot care for our patients fully. So the impact of the medical home model or collaborative care is all of these things here: decreased ED visits, decreased hospitalizations, decreased length of stay, and these are for higher acuity patients. And so that is a big deal. And so I want you to keep all this. I promise we're going to talk about hypertension, but I want you to keep all of this in your mind when we start to talk about these patients and how we're going to provide the full scope of care for them. So we've heard a lot about maternal mortality, and I'm going to go quickly through these slides, but I feel like I can't not mention it, particularly when we're talking about a topic like hypertension. So we've seen an increase in maternal mortality in the U.S. over the last 20 years, so much so that it's the highest among most developed nations. When we look at the causes of maternal mortality, we're all very familiar with this. We know cardiovascular disease is at the top, followed by infection, hemorrhage, and you can see where hypertension is right here, accounting for about 10% of maternal deaths. Some sources will say up to 16% of maternal deaths. And the reason I like to point this out is because we know that this is some things we can't move the dial on, but I feel like this is not one of those things. We can absolutely move the dial on hypertension. So I've been talking about maternal mortality for a long time. Well, not that long, maybe like 2 years. But I say that looking at June. She's like, no, you haven't. But when I first started talking about it, I'd only talk about maternal mortality. But as I've, grown and learned, I understand the relationship between maternal mortality and infant mortality. So it's really hard to talk about one without the other. So when we look at infant mortality, you don't see that upward slope like we see with maternal mortality, but you do see that we kind of hover and there's a plateau. When you look at the causes of infant mortality, you see that obstetric conditions are here, and you see that prematurity is also here. So this is directly related to the care that we're providing our moms. So when you look at prematurity, we know all the obstetricians, nurses, even NICU nurses in the audience, we know that a lot of the maternal conditions result in a preterm delivery. So when we understand the relationship of that, we can coordinate with our teams better, we can provide better care for our patients. So maternal mortality doesn't just happen. It's a spectrum. So we see, I like this pyramid. The bottom is uncomplicated deliveries, and I feel like I've had like 2 of those in my whole life. The next is, the morbidity. So you start seeing hypertension, diabetes, postpartum hemorrhage, then the severe maternal mortality. So we understand that this is a spectrum. So it's not just you get into the hospital, mom comes, she has a postpartum hemorrhage, provide the best care there. The best care needs to be in the office, at admission, during the admission, at discharge, and following discharge. It's a continuum. So the problem, and I'm going to go through this really quickly because I think we know most of this. So we know that hypertension is one of the leading causes of maternal mortality. It occurs in approximately 5 to 10% of pregnancies worldwide, accounts for 15% of preterm births, so that's part of that big piece of the pie that I was showing you. Many of the infants born to preeclamptic moms will be admitted to the NICU, will have growth restriction and neonatal death. And it's really expensive. In 2012, it cost the United States over $2 billion. So what do we do now? How do we provide care for our patients? So we have our super cute pregnant mom. She comes in, you take the history. She has a previous history of C-section, depression, gestational diabetes in the previous pregnancy. Your MA tells you she has elevated blood pressure. And on ultrasound, she has twins. This is like our typical patient at the center. Every single patient is like this. So what do we do? What do we do with this patient? So even before you know that a patient has an elevated blood pressure, you need to recognize the risk factors. And so I usually don't read every word on the slide, but I'm going to read every single one of these because a lot of them we forget. I forget. So nulliparity, we know. Multifetal gestation, sometimes we forget that. Preeclampsia in a previous pregnancy, chronic hypertension, gestational diabetes, pregestational diabetes, thrombophilia, and lupus. I feel like a lot of people forget that sometimes. Also, pre-pregnancy BMI of greater than 30, that is the majority of my population. Antiphospholipid syndrome, maternal age greater than 35 years, kidney disease, assisted reproductive technology, and OSA. So a lot of these on the list, I feel like everybody in this room would forget like at least 3 of them, maybe 5. So this is really important, and I think it's really important to make sure that you're always looking at the guidelines so that you know what your risk population is, even before they have an elevated blood pressure. So this is not going to be an aspirin talk. I do a lot of aspirin talks, but this is not one of them. But I feel like we have to talk about aspirin really quickly. So once you identify a patient who has risk factors, we should know what ACOG and the task force recommends. So the recommendation is 81 milligrams of aspirin for this high-risk population. So history of preeclampsia, multifetal gestation, chronic hypertension, type 1 and 2 diabetes, renal disease, and autoimmune disease. So that's like lupus and a phospholipid syndrome. So I read these every single time I do the presentation, and I've done this presentation a lot, right? And so I had a patient with lupus like 2 weeks ago, and I didn't start her aspirin. So that's why, I was going through this presentation, I was like, oh man, but she's less than 12 weeks. So I still have time. But that's why it's so important to keep reading the guidelines and understanding who your risk population is. So the recommendation is to start between 12 and 28 weeks and continue through delivery. It is also important to make the diagnosis. When you see a patient, make the diagnosis. So we have like a lot of things swirling around in our mind. We know high blood pressure, proteinuria, headaches, and most of the times, when you're reading it, when we all learned it, it seems like cut and dry. But in real life, it's like cut and dry 50% of the time. And so what I find in my practice is that sometimes it's difficult to make the diagnosis, and people don't want to put a diagnosis on the chart, but you have to, because if you don't, you can't make the management plan. So you have all these things swirling around. Is it gestational hypertension? Is it chronic hypertension? What is it? And so then what my providers will do is they'll just say, oh, she has elevated blood pressure. But this is not a diagnosis. So really try not to do this in the chart, because the person who sees them next doesn't know what that means. I don't know how to treat that. I don't know when she needs to deliver. So elevated blood pressure is not the diagnosis. So use your resources. There are a lot of resources. ACOG, the task force, AIM bundles. At Baylor, we have these really nice clinical standards that are in our shared site that the MFM team updates all the time, so we can just go and look. Look at the diagnostic criteria and make sure you understand it. The better you understand it, the better your patient will understand it. So that being said, we're just going to go back to the basics for like 10 minutes and talk about all of the hypertensive spectrum and what the diagnostic criteria is. So we have gestational hypertension, which is a systolic blood pressure greater than or equal to 140 or a diastolic blood pressure greater than or equal to 90 on 2 or more occasions. This diagnosis has to be made after 20 weeks gestation with previously normal blood pressure. So you see at the bottom, there's no proteinuria, no symptoms, and no lab abnormalities. So you cannot make this diagnosis if you have not done the lab analysis and you have not looked at the urine. So now we're going to talk about the conditions previously known as mild and severe preeclampsia. I have such a hard time not saying this. I do say it sometimes, but we're not going to say it today because it's not right. So preeclampsia without severe features, same blood pressure range, greater than 20 weeks gestation, previously normal blood pressure, positive proteinuria. So that's the difference between these two conditions. So now we go into I almost did it. Preeclampsia with severe features. So this blood pressure range is different. So you have a systolic blood pressure that's greater than or equal to 160, diastolic greater than or equal to 110, same, greater than 20 weeks, previously normal blood pressure, positive proteinuria, or any of these things listed below. So these are our PIH questions. Do you have headache? Do you have blurry vision? Do you have right upper quadrant pain? And so this is where it gets a little bit sticky, because sometimes, in my mind when I learned it, a patient always presented with elevated blood pressure and then they had proteinuria because they read Williams Obstetrics, but they do not. So sometimes patients will present with proteinuria first, and they don't have any elevated blood pressure. Sometimes they have elevated blood pressure and no proteinuria, but they have thrombocytopenia. So you have to keep all of these things in your mind very presently, because you don't want to miss these patients. So if they present with severe range blood pressures and none of these, they are severe gestational hypertension, which is managed very similarly to this. Okay. Oh, I thought we were going to the cases, but we're talking about chronic hypertension really quick. So chronic hypertension is before pregnancy. Either a patient comes in, they already have chronic hypertension, or it's diagnosed before 20 weeks, or they have any of these hypertensive diagnoses that doesn't resolve within 12 weeks postpartum. Then we have superimposed preeclampsia, which is a sudden increase of previously well-controlled blood pressure, frequent titration of medication on a chronic hypertensive, or the sudden increase in proteinuria. And so you can also have superimposed with and without severe features. So now we're going to a case. So I wanted to do that little really fancy thing where you click on your phone, but I'm not that savvy. So we're just once I read this, you're gonna shout out what you think the diagnosis is. So we have a 38-year-old G2P1 Hispanic female presents for prenatal care at 13 weeks gestation. Her OB history is significant for one previous C-section. Past medical history is significant for TIA in October 2019, maternal obesity, factor V Leiden deficiency. I didn't make this patient up. This is the first patient I looked in the chart. This is a real patient. Ultrasound reveals monodi twin gestation, and these are her prenatal vitals for her first 3 visits. Anybody have? Oh, y'all can't see him. So first prenatal care visit, blood pressure was 135/86. Second, blood pressure is 137/81. That's at 16 weeks. 17 weeks, she has 154/89, followed by 135/91. Chronic hypertension. So this patient has chronic hypertension. And so I find that a lot of times when you see a patient like this, the providers don't want to be the ones to say that she has chronic hypertension, but she has chronic hypertension. So remember the risk factors. I'm going to flash it up there really quick. This patient has a ton of them, even before she had an elevated blood pressure. So she's advanced maternal age. She has factor V Leiden deficiency. Oh, my little thing is off. So that's supposed to be around her maternal obesity, and she has monodi twins. So even before she had that elevated blood pressure, as a provider, you should think she's probably going to have an elevated blood pressure, or she's at risk for that. So diagnosis is chronic hypertension. Her initial PIH panel was normal. Her protein creatinine ratio was normal, less than 0.3. At 31 weeks gestation, she develops severe range blood pressures, and her protein creatinine ratio is 0.65. What's her new diagnosis? Superimposed. Okay, case 2. This is really quick. 23-year-old G2P0010 presents for prenatal care at 11 weeks gestation. She has a history of Crohn's disease, partial bowel resection. Prenatal care is significant for IUGR. She had normal testing. So she was induced at 39 weeks gestation, had a primary C-section secondary to arrest of labor. Postpartum day 1, she presents with headache, and these are her vitals. Can y'all see those vitals? No? Yes? Okay, what's her diagnosis? What'd you say? So I have a severe hypertension. Anybody else? So she's preeclampsia with severe features. So, and I put this case on purpose because a lot of people think that you cannot have preeclampsia after you deliver, and you absolutely can. So the patients can develop preeclampsia even at the postpartum visit. You know, when you see them, you should always be assessing them for preeclampsia. So she has preeclampsia with severe features. I'm not going to talk about inpatient management because I feel like that's outside of the scope, and I really want to talk about what we do with our patients postpartum. So pregnancy is a stress test, and everybody who's been pregnant is probably like, yes, it absolutely is. But it like really is a stress test for cardiovascular disease and also for diabetes. So women who have had anything on this spectrum, whether it's gestational hypertension, it's preeclampsia with severe features, they are at risk for cardiovascular disease later in life. So these patients are 5 times more likely to have longstanding hypertension, 2 times more likely to have any cardiovascular disease. This is whether you got MAG, whether you're on blood pressure medicine, all of these ladies are at risk. So the point of this is delivery is not the finish line. And I've been guilty of this, particularly when you have really, really complicated patients, really high acuity patients. You're just like, let me just get her delivered. Let me just get the baby out. But so that's a hallmark, but it is not the finish line. So when you look at the timing of maternal deaths, we see that almost 2/3 of maternal deaths occur outside of the week of birth. So some of these deaths are occurring before delivery, about 30%, but about 30% are occurring after delivery. So this tells us that this is not the finish line, particularly for our high acuity patients. So I like to talk about Will and Kate. They look like totally like they're at the finish line, right? This is when they came out. They just had their baby. But this is not how most couples are. They're more like this, kind of like, what just happened, man, you know? So I say this to say, discharge is a really important time. And I think a lot of times we skip over discharge. We go through discharge really quickly, particularly when our floors are full. We want to just clear out the room so we can bring in the next patient, but we really need to slow down for discharge. We need to make sure that the patient and the team understand the diagnosis. So that's why I spent so much time on the diagnosis, so that we all understand, so that you can explain that to the patient. So when the patient goes to her next new OB appointment, she doesn't say, oh, I had elevated blood pressure, because that provider has difficulty understanding what that means for her care. Elevated blood pressure is not a diagnosis. These patients need specific discharge instructions. So, on the floors, our nurses print out the discharge instructions. It's like whether you had a C-section, hypertension, diabetes, you all get the same packet. That should not happen. So these patients, when they leave, they need to understand what an elevated blood pressure is, what the symptoms are, and what to do when they have them. They also need customized postpartum follow-up. So typically, everybody has the patient's follow-up in 6 weeks, 6-week postpartum visit. That should not be happening. These patients really should follow up within a week of delivery if you're concerned about their blood pressure. And sometimes, if we're looking at the risk factors that we talked about before, sometimes I'll schedule a patient for a postpartum visit even if she didn't have an elevated blood pressure because I think she's going to have it. And we just had a patient a couple of weeks ago, never had an elevated blood pressure during delivery. The provider was concerned. She came in, severe range blood pressures, ICU admission. And so if she was not scheduled to come in for follow-up, we would have missed that. Also, your clinical team should know the questions to ask. They should really be in tune to these patients. So when they call in and say, I have a headache, this headache is not the same as someone who did not have high blood pressure. So as I mentioned, we really focus on collaborating care. So when our patients are post-delivery, our team is our generalist or our midwives. We have some really amazing midwives on our team. The care coordinators who are RNs, who are kind of behind the scenes. Pharmacists, registered nurse, and MA. So one of the things that we do is team communication. It's so important to communicate. So every time we have a patient deliver, our provider will send a message to the care coordinator, like this patient delivered. And so this patient delivered today, and you can see, are there any maternal complications? And yes, this patient had preeclampsia with severe features. And then the question at the bottom, hopefully you can read it, it says, will the patient need to come in sooner than the normal 4-week postpartum visit? And I can put yes. And then they say, why? And I tell them she needs to come in 1 week for a blood pressure check, because she had preeclampsia with severe features. So this has really changed the way that we're able to follow up on our patients in the postpartum period. So this is like this algorithm looks like crazy town. I know that. So this is our postpartum algorithm, and I put it on the screen. I don't expect you to be able to read it, but I do want to point out some things. So this star, we recognize that patients can present postpartum and still need admission to the hospital. So that is part of our algorithm. We also recognize that we may need to initiate medications on patients who previously were not on medication. That's also part of the algorithm. We usually will follow the patients for 12 weeks postpartum to determine if their blood pressure has normalized. So we've made the algorithm stretch out to at least 12 weeks to monitor blood pressure. Sometimes providers will discontinue the blood pressure medication at 12 weeks to see if they normalize. If they don't, we'll start them back. And this is really important. We understand the importance of the relationship between the primary care physician and the OB. Once they finish the care with the OB, if they have these high acuity diagnoses, they really need to be handed off to an internist, primary care physician. We really need to coordinate that care better. And this is really a hard piece. But we find that when you're in silos and you're not communicating with the primary care doctor, they don't really know how to appropriately care for these hypertensive patients. Same with diabetic patients or any other comorbidities that you may be caring for. So continuity of care. One of the things, I didn't mention that you may have put this together, but we care for, in my clinic, I care for 100% Medicaid and CHIP. So one of the big things we talk about is coverage. So Healthy Texas, is everybody familiar with Healthy Texas Women's? Yes. So it's a big deal for coverage in Texas. So we know that our Medicaid patients, after 60 days, their coverage terms. Most of these patients should roll over into Healthy Texas Women's, and this is a big deal for continuity of care because Healthy Texas Women's will cover treatment and diagnosis of hypertension, treatment of diagnosis of high cholesterol, diabetes, as well as your well woman visits. So if you're caring for the underserved population that have a difficulty connecting with a PCP, this is really critical. So our patients, and the card is pink, that's why I put it on the screen, because patients sometimes they don't know that they got the card. So if you say, did you get your pink card? They'll say, okay, well, I got that. They just didn't know what it was. So they should auto-enroll into Healthy Texas Women's. If they don't, they can contact TMHP and enroll themselves. This is a benefit that they should have, and that is really important for them continuing their care for their comorbidities. So this is a slide that our wonderful pharmacy team created for us because we kept prescribing the wrong medications for patients. So, you know, for OBs, we have like 4 hypertension medications like labetalol, Procardia, hydralazine, and I don't know if anybody ever gives methadone anymore, but those are our 4. So even when we're seeing patients in the postpartum period, we're prescribing those meds. But 2 things, those are not the meds that are recommended by the JNC8 and the American Heart Association, and they are also not covered by Healthy Texas Women's. So when we're talking about the social determinants of health and how to provide the right care for the patient, we need to know the right blood pressure medication, but we need to prescribe one that is covered. Otherwise, they can't take it. So the questions that we should ask is, may the pregnant patient become pregnant again? If they can, or if they will, you can prescribe a calcium channel blocker or a thiazide. If they're not going to become pregnant again, which no OB-GYN believes that anybody is not going to become pregnant again, so you can do an ACE or an ARB. Also a calcium channel blocker or a thiazide. So they did this other nice slide. Oh, beta blockers are not first line. So beta blockers are not first line. Remember that for in your postpartum period, it is not first line for treatment. And I'll tell you a story. So we went to the Healthy Texas Women's kind of conference, and I saw the director, and I'm like, I'm going to find her because she needs to put beta blockers on her formulary. And so I always believe, you have not because you ask not. The worst they can say is no. So I said, can you add beta blockers to your formulary? And she said no, because it's not the recommendation. And she's absolutely right. So I just want to make sure that we all understand that and we all are prescribing the correct medication in the postpartum period. And so this is just the same thing, just prettier. So if they can become pregnant again, you want to stick to the calcium channel blockers or the thiazides. And probably nobody in this room is going to do this, probably, because we all are reproductive health. So nobody is probably going to prescribe ACEs or ARBs, but you can if your patient is not going to become pregnant again. No beta blockers again. So I'm going to wrap up here, and I actually wanted to share my own personal story. This is actually my son. So my son was, I was diagnosed with preeclampsia with severe features at 30 weeks gestation. So my son delivered at 31 weeks by stat C-section. He was 2 pounds, 13 ounces. I was in the hospital for 10 days with an ICU admission, and my son was in the hospital for 52 days. So when I talk about hypertension, I talk about it as a provider, but also as a mom. And I think about my discharge course, and my physician did exactly what I would have done, which was not comprehensive enough. I was discharged home on 3 blood pressure medications. I didn't have a 1-week visit. I titrated my own medications because, that's what we do. But I look back at that, and if I didn't know what to do, or even sometimes if we feel like we do know what to do, we still need someone who's more objective than we are. And so it taught me a lot about how I should manage my patients in this postpartum period. This is my son now. He's 4. He's healthy. He's happy. He's cute, I think. So that is it, and I'll take questions.
Hi, my name's Laura Young. I'm with the Nurse Family Partnership Program up in Tyler. And I want to share a story to go along with yours. The story is actually an active case we have right now. This mom was elderly, by our definition, in pregnancy.
So was I.
Black woman, not morbidly obese, but definitely overweight, and first-time pregnancy. We spent time with her, worked with her throughout her pregnancy. We teach all of our moms how to take their blood pressure on an automated cuff, and we actually give them an automated cuff. Had not had any history of hypertension during pregnancy and was not treated for any. She delivered a healthy baby, had hypertension postpartum, and knew about the signs and symptoms based on the training, the education that the nurse gave that mom, and she took that. She also shared that with her sister, who she lived with. Got home, had been home a couple of days, and had elevated blood pressure. She knew that because she took her blood pressure. She had a severe headache. They took her to the ER, significantly elevated blood pressure, put her inpatient, gave her medications. She was discharged the next day. A couple days later, same thing happened. Had a headache. Sister had her check her blood pressure, and the mom said, well, I've got these medicines. I should be fine. It's okay. I don't need to go back. Sister had her go back. In the ER, they treated her with medication again. Was starting, and the blood pressure was decreasing. They were going to send her home, and she said, I'm not going home. She stroked in the ER.
Oh, God.
She's now in a rehab facility, right side flaccid, but working through the recovery. Because of this situation, because of a simple blood pressure cuff, because of some very basic education on warning signs, and her ability and her sister's ability to advocate for themselves, which I'm going to attribute that to the nurse and the work that she did with her throughout that pregnancy. She's alive. She should not be alive. And I just want to say that this is stuff that's happening every day. We just happen to have been, I feel very fortunate to be in the right place at the right time to touch this mom. And now this baby is going to have a mom. And so baby's great. Mom is now speaking. Didn't have any of that. She was quite unresponsive. So I just want to share that story. This is happening.
Thank you so much for sharing that. I think it's amazing that you all were able to do that education. One thing I do want to add about that case to the room is when patients present in the postpartum period with preeclampsia, they still need MAG. And a lot of, I've worked in a community hospital before, and they were saying, who are these people starting MAG postpartum? And I'm like, the people that are following the guidelines. And I say that because I know there are a lot of clinicians, a lot of nurses in the room, and nurses are huge patient advocates. So you can do like what they were talking about in the session earlier, like, have you thought about MAG? So if you have to, drop that line a time or two, do it.
She wanted to say something first. She got the mic, and then I wanted to say something.
Oh, me? Yeah, okay, cool. Some of the things that you were getting me to think about more was in those conversations, whenever these things are being diagnosed, I'm just thinking of a personal example of whenever you hear something, it's difficult to feel like, okay, now what can I do next? And I know a lot of the times we can pass on information and referrals and resources and medicine, but there's a lot going on. And I was just wondering, do you have any ideas, solutions of just those things in those moments, in those dynamics, those conversations of how to remain solution focused or highlighting the strengths in those people who are delivering or will be delivering? How can we ingrain that in that conversation so that when they get those resources and they get that information, they're at home, there is that, that notion in their head that this isn't something that's another thing that they have to worry about, another stressor. And I didn't know if there were any solutions that can come up in those conversations. And if you've thought of any or heard of
So
any.
I think that's a really good question, and I think that everyone in the room can help with this. And I know, June, you're going to remember that we talked about this after. I think what happens traditionally is that when the baby is born, the focus shifts away from mom totally to baby. And so as a community, if we help mom understand that she is still important, her health is still important, that will help with that conversation. So, as a mom, you're so busy and you're so tired and you're not eating and you're depressed and stressed and all of that. And you think that, we paint this picture of motherhood like you are Superwoman and you can do everything and you're expected to still do those things. And so as a community, if we can say to moms, hey, I know you're tired. Stay at home, rest. And I'm saying this as a NICU mom. And so, there's a lot of pressure on NICU moms to always be in the NICU. But you can't sleep in the NICU. You can't eat in the NICU. You can't do everything in the NICU. So give moms a pass to say, hey, take care of yourself. And so if that's kind of the theme that you're having in your friendships and your families, when you notice something, say, hey, remember that you have to take care of yourself. Or if you're having a headache, maybe you should go in and get your blood pressure checked. Things like that.
The ER is very important as far as them understanding or remembering to say, when did you deliver last? Or, that kind of, and so part of when we discharge patients, we tell them, if you happen to come back to the ER, tell them.
Yes.
This is when I delivered. Please reach out to my OB. And so we've told the ER, just call us. We don't care. Wake us up. It's not going to hurt anything. And that happened to us because we had a patient, I don't know if she was 3 weeks out, can't remember, but she came in with elevated blood pressure. So they consulted the hospitalist. And all night they helped her with her blood pressure. And then she seized, and then they got a neurology consult. Then the neurologist called me and she's like, well, I've already started MAG, but I think it was an eclamptic seizure. And that was the first I had heard of it. And nobody had ever thought to consider the fact that she was in that postpartum period.
Right.
So we had a big conversation about it and just give us a call. But when the surveyors came recently, for the leveling, they really made sure that, are you communicating with the ED? And they wanted to have a meeting with the ED. Like, do you know this is serious? Do you have the protocols? Do you feel like you can call the OB at any time if you need a second opinion, so that these things don't fall through the cracks just because she doesn't look pregnant,
Right.
anymore?
I think that's so important. And we just had our levels of care visit in October, and that's one of the questions they asked our ED docs. What do you consider postpartum? And so, it's not 6 weeks. I think I'm still postpartum, but really it should be, at least the first year. So I was just talking to one of my colleagues, and I said, I feel like every ED physician or every intake person at the ED should ask, have you been pregnant in the last year? Because it really changes how you assess the patient.
Yeah, the good news is that is a campaign. It's similar to the One Question campaign. So physicians in the ED are getting reminders. I'm starting to see little babies on charts for
awesome.
moms. So there is some awareness that's coming out. My background is in care coordination. I'm a registered nurse with an OB background, and I'm working now with an ACO here in Austin, and we're really kind of taking some of the stuff you guys know from Studer, that postpartum call, but not doing it for customer service, really doing it to continue the conversation with the mom. And, in a good population, 95% of your moms are going to have a normal physiological recovery. It's those 5% of those moms that you really have to grab.
Right.
So my challenge is to try to get those discharging nurses like you spoke about to use the A1 flyer that we saw earlier yesterday. There's 8 key questions, 8 key things. Hypertension is on them. We've heard all the stories about the postpartum shortness of breath, which is the PE. We've had the moms that have had the postpartum hemorrhages. I mean, everything we've talked about is on that flyer. A1 does sometimes charge for that flyer. I can make a pitch for the Texas Nurses Association. They have a version of it that's free, and I'm pretty sure they'll co-brand it with your facility, just FYI. So I'm working with a team. We're trying to launch a project by the middle of the year where we're doing intervention calls. I'm fighting with people about what the definition of the World Health Organization has a definition of postpartum, which is 365 days versus ACOG, which is 42. So depending on your kind of scope and philosophy, I very much believe that full year of postpartum is necessary for full recovery. After the 6 months, not only does hypertension kill women, but so does the opioid issues. And the postpartum depression pickup is so much more intense between month 6 and 12. So with the group of nurses that I'm working with, we're trying to design a program that would just be telephonic because it's cheap. That's all we've got right now. There's been some studies where texting, which has been real effective, giving moms opportunities to get information just on a text, because I think 85% of moms have smartphones now. So that's another way to reach out long-term, sending phone numbers, sending resources through the text if they need to call back in. There's a person that they can call back into. So I'm hoping that we can connect with these women and keep them in the loop, like there's someone, maybe they feel bad and they haven't thought about us for a while, but then they get a text or a message and they're like, oh yeah, maybe I do want to talk to that nurse. So trying to keep that conversation going.
Thank you so much for that. Oh, we're out of time. I'm going to just say one more thing. But keeping the patients connected is so important, and that's why I'm going to give a shout out to NFP and also a shout out to the Healthy Start Initiative, because these are programs that really do that. Thank you, guys.
Thank you. Thanks, Dr. Giwa.
Okay, lunch is going to be upstairs and right outside the ballroom and in room 301. There will be also the 2 lines in 301, 2 lines right out in the ballroom. And then get back to the main ballroom at 1:15 for multidisciplinary presentation, implementation of quality improvement, practical experience.